thank you to our colleagues for telling us about all the good work that they do. So, what can we do in our GP surgeries really to maximise initiation of breastfeeding for new mums and help keep it going as long as possible, as long as they want to? The first thing we can do is make breastfeeding a normal thing to talk about. So, mention it at every possible opportunity. When the couple comes to see you for their preconception advice, try to get a word in there. And then when they come to see you for their first antenatal visit, when they've just found out that they're pregnant, they're very happy, make sure you mention it then as well. And every time that you see the pregnant woman, if she comes to see you before she actually has her delivery, and then they're used to hearing about it, and actually might be a good idea to give it a go. You can give the statistics on breastfeeding if they ask for it, and also to help. There's this myth out there that babies who go to hospital with medical problems when they're newborn or have to stay in for a couple of weeks, and they end up being discharged on formula and not breastfeeding. It doesn't have to be that way. What women need is the right information and the right support if they want to carry on breastfeeding. That's really the most important thing. If a woman comes into your consulting room talking about any kind of breastfeeding issue, make sure that you are able to signpost them to people who can give them a bit more time, a bit more in-depth support, like at the infant feeding cafes, at Latch On. So they can have their feet really looked into and have their latches optimised. Make sure that you make your surgeries friendly place for women to sit and breastfeed. Even if you're not part of the Breastfeeding Welcome initiative, there are things that you can do. For example, just letting in a lady off the street with her baby, even if she's not a patient, maybe it's raining outside and she just needs to feed her baby for 5 minutes, to allow her to come and sit in your waiting room. Encourage your staff to offer breastfeeding ladies if they need a cup of water or if they need any other sort of assistance. It helps make them feel comfortable in your environment. And then finally, try and make sure that you code the breastfeeding data when you're doing the 6 to 8 week checks. Probably, as we've heard from Claire, it appears that when we're actually coding the 8 week checks properly, the breastfeeding data is being captured, so that's great. We just need to make sure that we're coding things in a way that when other people go into our email systems, they can extract that data. That's really helpful. Okay, now we're going to talk about medical issues that women might come in to see you with regarding their breastfeeding. I think the most common one that they come in with is complaining of painful nipples. It's quite often quite early in their breastfeeding journey. They'll come and say, oh, I'm breastfeeding, but it really hurts and I don't know what to do, and they're quite distressed about it. First thing, always, is encourage the lady to go and have their latch checked by a breastfeeding supporter or a lactation consultant. We don't expect GPs to do this. You don't have time and you don't have the expertise. Please point them in the right direction. And then tell them to come back if that doesn't sort it out. So if the latch is absolutely fine, the next most common problem is thrush. So it's very common for ladies to get thrush on their nipples or the baby to get thrush in their mouth. Now the baby may or may not have removable white plaques on their tongue or on their buccal mucosa, but the mouth may look absolutely normal. And on the mother's nipples, they often look completely normal. Sometimes they look a little bit dry and cracked, but they can look entirely normal. So if both of them look normal, I would suggest that you give them some treatment for oral thrush. And you have 2 choices. I recommend using Miconazole oral gel after feeds 4 times a day. So that needs to be spread onto both the mother's nipples and the areola area. And then mum should use her little finger to put enough to cover the length of the fingertip and smear it around all the baby's gums on the inner aspect and the outer aspect as well after feed, so that it sits there and then it works. And that should be continued for about a week. An alternative to Miconazole oral...
So that gel absorbed through the skin? So the gel will be absorbed through the skin?
Yeah, so it's sitting on the skin and it doesn't need to be absorbed through the skin, it's just sitting there and dealing with the infection. But the important thing is that mum and baby both need to be treated at the same time. If you only treat one or the other, then the infection will just continue to grow. And so please remember to use the oral mucosal gel, not the cream. An alternative to this is nystatin drops, QDS. That's a little bit, it's easy to apply for the baby, but it's a bit more tricky to apply onto the skin. issue that we often see is mastitis. So a lady will come in with a sore, painful, tender, often with a red patch on it of her breast. She may or may not have general malaise, fever, and have flu-like symptoms. So it's important to examine the breast so you know what you're looking at, find the tender area, and then give a course of antibiotics for a week. So flucloxacillin, 500 milligrams QDS, is safe in breastfeeding. There are trace amounts in milk, but it is appropriate to use it. If the woman is allergic to penicillin, you can use erythromycin, 250 milligrams QDS or 500 milligrams PD. There are only small amounts in breast milk, and it is not known to be harmful. Women do occasionally get breast lumps.
During mastitis, usually they will not be able to breastfeeding from that side.
No, okay, so when a woman has mastitis, the advice should be they should continue feeding from both breasts.
So painful,
Because
you're a lady and so painful.
you need to encourage her